Hey, I think we can get started so we don't delay anybody. Um, Welcome, everybody. My name's Katie Harris, and I'm the governor for the Iowa chapter of ACP. And I'm just very excited to have Dr. Brent Burr and nurse practitioner Sam Malley here with us today to present a great case. And I really was hoping that, having cool cases from people all across Iowa would be a great draw for other ACP members to just join in our community. So if anybody on here has cool cases that they'd want to talk about, please let me know and we would love to have you present. So without further ado, I'm going to hand it over. Oh, I'm sorry, Zoom etiquette. Make sure your microphones are muted. Screens, you can have them on so we can see you or turn them off. I understand most people might be eating right now, so I might turn mine off at some point too. But there is some participation, so please unmute yourself and participate whenever Dr. Burr and nurse practitioner Sam Malley ask for it. So without further ado, I'll hand it over to you guys. Thank you so much for being here.
Great. All right. Well, thank you, Dr. Harris, for inviting us and allowing us to do this. So our case is, we're from People's Clinic, which is a community health center here in Waterloo, Iowa. And we have some interesting things that walk in on a daily basis, and this is one of them. So we wanted to talk about it, call it an invisible illness, a case from our clinic. And I'll let you know kind of at different points, kind of like a morning report, when I want to get your thoughts and see what you think is going on. So to start with, our case is with a 34-year-old male presenting with 3 weeks worth of back pain. Pretty typical presentation, pretty typical complaint. The remarkable thing was that he said it was preventing him from working. So for the last 3 weeks, he hadn't been at work. The pain was moving down his left leg. That was the most prominent part of the symptoms. It was strongest in his lower back and his left buttock. And he felt like it was needles along with the pain sensation that accompanied with that in those areas. Just a general review of systems showed really nothing else that jumped out. No cough, fever, chills, nausea, vomiting, diarrhea, no skin changes, no neurologic changes, really nothing else that he could think of to go with that. And in terms of reviewing his overall history, this is a relatively young person, so he doesn't have any medications, no allergies that he knows of, no past medical history of significance that he's aware, no surgeries, no family history, also really not a drinker, smoker, no drug use. He's married and has a wife who was pregnant at the time, but really that was it. So not a lot to go on to start with. So this is a pretty generic introduction. So when you see something like this, what do you think of in terms of a differential? Please feel free to shout out what you think.
I'm often thinking of lumbar radiculopathy in these younger patients. Like, is there something there that's contributing?
Okay. What else? So thinking of other processes, like, just broadly, lumbar radiculopathy is one, spinal stenosis is another. You might think of a recent injury or a fracture. He's young, he's working. Maybe he's in construction, maybe he's doing something else that could have caused that. Are there other broader things you might think about if you're really, kind of widening differential back pain?
The red flag ones would be like malignancy, infection, things like that. It doesn't sound like he has some of those symptoms, but that would be broader.
Yeah. So sounding more like, as you said, radiculopathy, spinal stenosis, those kind of things. But thinking more broadly, we have a basket of other things that could go along with it. So that's probably a good introduction to what you're thinking. And that's, a usual clinic day kind of thing. See this all the time. So let's get a little more information and see what we find. These are the vitals that he had at the time of clinic presentation. So take a look over those. What do you think of them?
He's very little.
Yeah, like little,
is that
small.
a different weight? Is that different than his weight a month or two ago, or is it the same?
Good question. We'll get to that.
the right track.
but definitely a good thought. And that does definitely jump out when you think about his height and his weight. Anything else with his vitals? Yeah, that's probably the biggest thing. And I like this because how many times in a day you're seeing all sorts of patients back and forth, you maybe have 1 second to look at the vitals, but sometimes it could be really crucial. So here's some more information in terms of the physical exam. And you take a look over that, anything that jumps out at you that you notice.
Frail, older than the stated age?
Yeah, so I know that that's a subjective description, but you know, especially for someone who's young, that is a significant thing to notice, as a significant change. Now, obviously, his lower extremity and back exam seems pretty benign at this point. Nothing on straight leg. He does have some, you know, issues with extension of his leg, which could be related to the process going on. At this point, there's also a cervical, axillary, and inguinal lymph node exam that's included, given the comments about the frailty, but no adenopathy noted. So I'm going to add a few more of those details and add on to what was mentioned earlier about the being small. We reviewed records that were available in the clinic and found that from February 2015, he had lost 21 pounds. So at least over that long period of time, there was a difference. He had no medical insurance at the time of the visit. He did, on further questioning, mention he had some tests, an endoscopy in the past, a couple years earlier. Doesn't recall what it showed, and he was lost to any follow-up regarding the test results. And further review of symptoms really just showed the back pain and the weight loss as being present at the time of presentation. So I want to open this up because, you know, we as primary care practitioners experience this every day. We have a patient who has no insurance. They have pretty significant changes in their weight. They have pretty significant presentation. What do you want to start with testing? We can only do x-rays and labs on site right now because he does not have insurance. So
I think a CBC would be instructive because if this endoscopy was for some type of like ulcer and he's anemic, or if he had like celiac and he has bone loss or something like that, that could be causing a fracture, vertebral fracture, like that might alert us to which direction we need to go for further testing.
yep, definitely. What else?
And Dr. Burr and Sam, I saw in the chat that they're asking some more history questions too.
Yeah.
Where did they said, where did he grow up? Any unusual dietary or medications? And then they suggested CBC, CMP, X-ray of LS spine, lumbar sacral.
Yeah, so all of those are really good suggestions. They're kind of jumping ahead of me, so I'm going to get to that in a second. But yeah, all of those tests are really good suggestions. Anything else that might be helpful in tipping you back and forth? Like,
And you guys didn't get the opportunity of seeing the patient, but it cannot be understated how frail this patient looked. How much older? Probably at least 20 years older than stated age. So at that point, you know, red flags, there's concern. So we're going wide with our exam and workup.
right. So another thing I think about is, you know, tests that might change your differential completely. So especially in somebody who shows frailty and signs of weight loss, HIV would be important. Thinking of more disseminated diseases would be important because that then starts to include a huge category of stuff that you don't want to mess.
They also
So,
asked for an
yeah.
ESR,
Yeah.
and also how the teeth look.
Yep, yep,
Poor dentition.
yep. Yeah, so concerns about a discitis, osteomyelitis definitely goes along with that. So all good thoughts here. So that gets to the follow-up question in the chat. Very apt to bring that up. What else do you want to know? What other information would be helpful? Well, let's fill that in. So we were able to get some outside records and some other info, and we found that the patient was last seen 7 years earlier for acute dental pain, but really no other paper trail at our clinic. We did get outside records from a local office about the CGD and some other testing, and we found he'd actually lost 54 pounds from June 2020 to June 2022. So he had gone up and then come way back down. More history, he's actually from the Marshall Islands, that's out in the Pacific. He came to the United States about 18 years earlier, 2004, lives with his wife and kids. As I mentioned, wife is pregnant. And he had mentioned in the past some kind of quote unquote cancer, maybe. He's not really sure because he didn't see a doctor, but he said he was living in the Marshall Islands and his grandmother gave him some kind of herbal remedy to cure him and he thought he was better. So that's what we could further glean from his history. Now, in terms of further testing, so the day that this patient was seen, we definitely cued in on the weight loss. So we added testing CMP, CRP, SED rate, CBC, as has already been mentioned, HIV as well. Also added a QuantiFERON Gold, which is a TB screening test, hepatitis panel, and we did do the lumbar X-ray and a hip X-ray, as we do have X-ray on site. So we'll quick go over some of those results. This might be a little hard to see. Any thoughts about the CBC and the CMP we see in front of us?
So we look like we have an anemia there. What kind of anemia does that look like?
Interesting, his platelet count is elevated, so that makes you think of like inflammatory states. His MCV is on the normal end, so hard to say for sure. And his RDW is okay. His ALK phos is high, which is kind of interesting when you come to think about bone disease. Like that might be kind of a bone relation.
Yep, absolutely. So yeah, nothing that is huge jumping out as hugely abnormal, but the anemia is definitely there, elevated platelets there, slightly elevated ALK phos, all could fit together with that, but what's going on in the back. So maybe something more than just your run-of-the-mill back pain issue, as we already discussed, along with the weight loss. So further testing, HIV and RPR were negative, but the SED rate and CRP were quite high. SED rate was 100, CRP was 87. And as we know, those tests are more valuable the more abnormal they are. So definitely says some secondary processes going on there besides just a chronic pain process. Hepatitis is negative. QuantiFERON Gold, that screening test for TB, was positive. X-ray did show some slight changes, lever curvature in the spine, but didn't show any lytic lesions, nothing else that jumped out as severely abnormal, at least on read. So what are people's thoughts after seeing these results here?
Somebody put in the chat chest X-ray.
Yep, that is a next step. We'll talk about that. Else.
A SED rate of 100 is bad. Like that's you know, there's not that many things that get you over 100. So that would be a very huge red flag for me.
Right, exactly. So you definitely know at this point, there's something wrong. You know, there's some inflammatory process going on. Now you have to figure out what it is. And the CRP, it's not quite 100, but I know 100 is very sensitive for bacterial infection, actually. So if you see a very high CRP, that can push you down a road, as Dr. Harris had mentioned, concern about osteomyelitis, discitis, things like that. All right, well, let's fill this in and finish what happened here. So in the interim, we agreed with that recommendation for the chest X-ray. Given he had the positive TB test, the weight results, and the high inflammatory markers, we at least needed to get that done and also bring him in for other testing and evaluation. We wanted to get him set up for insurance. He fortunately qualified for Medicaid, so we called to try to arrange that, try to get him in. Patient informed us that he was out of state visiting friends and family, but he'd come back in a couple of weeks. So of course, you love to hear that when you know something bad's going on. Really tried to impress upon him this is immediate and we needed to see him right away. Didn't come right away, but did come back 2.5 weeks later and came to clinic for a visit. So we decided to send him over for the chest x-ray first so we could look over the results. And this is what we found. Anybody want to read that?
Oh boy, you got some badness going on in the upper lobes there.
Definitely upper lobes having badness, but really also all over. You can see this diffuse infiltrate really predominantly in the upper lobes, as you said. So what are people's thoughts? What do you think this is going on in him?
Somebody put in the chat, disseminated TB, and they're
Yeah.
kind of surprised without like other symptoms and signs.
Exactly. So this guy walked in really not complaining about anything much else except the back pain. And he is sick. So if you look at this x-ray, the thing that jumps out, a couple things. Upper lobe predominant, bilateral, that's usual, the traditional TB that we think of. But TB can present in a lot of ways. And you can see almost like little round holes. I don't know how good you can see the differentiation on the presentation, but you can see cavitary lesions there in the upper lobes. So this is pretty impressive. So yeah, that cinched that for us.
And of note, the radiologist didn't read this as specific to TB. The radiologist did not say that. So just as a reminder.
All right, so when we see something like this, our usual next step is we want to confirm that diagnosis. We want to get sputos. So we had him sitting in clinic. He was clearly sick. He clearly showed x-ray that was consistent with active TB. We also knew that he had the severe back pain and the SED rate and all that stuff tied in with involvement somehow into the back. What would you think of as the cause of that now in terms of an etiology? POTS disease, exactly. So that's what we were worried about. And whenever you have POTS disease, you also have to think about CNS involvement from TB, because whenever it's getting into the spinal column, there's a chance that it could go to the brain. So this was a guy who had poor follow-up, very sick. We thought he needs workup that we can't get done right away here. He needs treatment, so let's get him to the hospital. We did. He was admitted to a hospital here locally. Sam will describe kind of what goes on and what happened after that.
So he was hospitalized for a period of about 10 days. And honestly, upon leaving the clinic to go to the hospital, we were very confident with what it was, but actually the hospitalists weren't. They did do sputum samples, which did show 4+ TB bacteria, which if you're not familiar with sputum samples, that's really just how much TB do they see under the microscope. So 0, 1+, 2+, 3+, 4+. And then they did DNA testing to confirm that, yes, this was MTB complex. So he was infected with TB. The part that we kind of left out in the beginning, because it really gives it away, is that actually that previous ER visit where he had lost, that let us know he's lost 54 pounds. He actually had a CT scan that showed peritoneal carcinomatosis that the radiologist read as consistent with TB peritonitis. And the ER physician wrote, patient states he's never had TB. So the patient had abdominal TB 2 years prior, had a negative chest x-ray at that point. So when he was initially admitted, they weren't doing any additional testing. And so we called and said, hey, did you happen to see this old CT scan? So they repeated the abdomen and just showed, florid TB in there. And then also had some lytic lesions at L1, which is kind of typical for POTS disease, T12, L1. So that kind of confirmed that this man has disseminated TB. And they did do some tissue cultures there as well. Oh yeah, we kind of went over that. Yeah. But then, so then of course, then the concern raises for CNS TB. So an MRI was completed and showed tuberculomas in the brain. So, you know, this man really didn't have a lot of symptoms, but he has TB absolutely everywhere. And in a normal situation, you would want an LP in this situation to rule out TB meningitis, but for various reasons, this wasn't done for this patient. And we did one later, and it was pretty consistent with what was probably resolving TB meningitis. So the decision was this was active pulmonary TB, likely had gastrointestinal and peritoneal TB as well as Pott's disease with TB of the brain, CNS involvement. And he also had some findings suggestive of liver, laryngeal, and other lymph node involvement. So the liver involvement, he had that high alk-phos, but also high GGT and low LFTs. Liver TB is really hard to see on any type of imaging. So, and like I said, this man had TB absolutely everywhere.
All right, so we're going to talk a little bit. Sam's going to go into some detail here about this case. This kind of kicked off a series of cases for us that we have seen in this area from TB. And you might have seen some emails from the state actually notifying people about increasing diagnoses and incidents of TB cases here in Iowa. We actually are experiencing that quite strongly here in Blackhawk County, and we're going to explain a little bit about why we are and why we think we're going to see more in the future.
So overall in the US, we generally have a pretty low incidence of TB, but we're not treating the whole country. We're not treating the whole state. We're treating the patient in front of us. And if they're not born in the United States, then we have to consider these infections that come from where they are from. These patients oftentimes have a high incidence of TB if they're from outside the US, pretty much unless you're born in Europe, Canada, the US, you are at higher risk for TB infections. And these patients often get missed. They may have poor access to healthcare where they're from. So it's not common practice to go into a primary care provider's office. So when they come in, they're really sick. And then if things don't get resolved right then and there, or maybe they get a little bit better, they don't follow up. And that's what what this patient experienced. And they may not express symptoms until it's quite bad. And he did not report a cough at all. And he finally, after he was diagnosed, did say, well, maybe I've had a little bit of a cough. So when we talk about TB globally, TB is actually one of the top infectious killers. And it's kind of interesting. We regularly screen for HIV. We regularly screen for hepatitis C. We screen for a lot of infections, but many people don't screen for TB regularly. And in 2021, 1.6 million people died from TB, and then another 10.6 million became ill with TB. So it's actually quite common. And nationally, most of our cases come from Texas, California, New York, specifically New York City. And we really have been declining in our TB rates until about 2020, which I don't know if anyone else experienced some changes in 2020, but maybe we weren't detecting things as frequently. But in the United States, there's an estimated 13 million people with latent TB infection, which those people maybe are active cases later. And in the state of Iowa, we've had a jump in cases. In 2021, there were 45 cases reported. And then just a year later, there's 60 cases. We hopefully all got the IDPH provider update notification on TB. But in 22, IDPH reported over 1,100 LTBI infections. So this is still something very common, even in Iowa. And Dr. Burt put on here, at Peoples alone, we've treated 14 active cases since July of 22. A lot of these people, if you look at the counties, meatpacking plants are common places for people to congregate and work. So if you look at statistics about who is getting TB in the United States, if you just go by numbers, you're going to find that it's people born in Mexico, people born in India, China. But we're not treating the whole country. We're not treating the whole state. We're treating the patient in front of us in our exam room. So what this graph tells us is, what is the incidence rate for a country of origin while they're in the United States? And we locally see a lot of people from RMI, the Republic of Marshall Islands, Republic of Congo, Myanmar, that's going to be our Burmese population, and the Federated States of Micronesia, which are going to be our patients who are from Chuuk, Pohnpei, Koshrai, and Yap. So if I have a patient that comes into the clinic and they're from somewhere on this graph, they're at very high risk of having TB as compared to other populations.
And as you can see to the right, it mentions the US incidence rate of people US born is 2.4 per every 100,000. And you can see the Marshall Islands, it's 170 to 100,000. So that's a huge difference in rate. And just if you're thinking about pretest probability, that changes what you think completely in terms of what might be going on with this person in front of me. Go ahead.
And so we have a lot of Pacific Islanders locally, and if you have them locally, I think it's important to do some digging and information on these groups of people, but they're unlike other populations because they don't require any medical screening. So on that list over there, our Congolese population, our Burmese population, they require an immigration physical. But the Pacific Islands are under a free association agreement. So they can come to the US without a visa, without any additional like testing, no immigration physical. And we do that because we did a lot of nuclear testing in the Marshall Islands previously. And that is also part of the reason why there's some mistrust in the US healthcare system. The medical care there is very rare. Dr. Burr and I have been able to talk to a lot of people about cultural things that we can do in the clinic. And what we've come to find is that most people that get care in the Marshall Islands and these other Pacific Islands, they don't have primary care. You only go when you're sick. The only type of chronic care clinic is really probably going to be diabetes. And these patients are eligible for Medicaid if needed. And they may be going back and forth. So even if you test somebody one time, it doesn't mean that they don't have TB when they came back.
One other important thing is people often go back and forth to visit family if they're from another country. They might be supporting other family members in that country, giving money. They might just be coming back and forth to kind of keep a connection. But this is interesting. Almost half of all international travelers living in the US are actually visiting friends and relatives. So VFR is a special designation. And even the CDC Yellow Book, which are the guidelines for travel medicine, have a separate chapter on VFR because it changes the risk of what you have to think about for disease. And so being aware that people are traveling back and forth a lot, knowing their country of origin and what their risk might be is very useful for helping diagnose.
And one point that I didn't touch on there is that 1 in 4 people with TB also has diabetes. TB and diabetes really work together. So if you have a patient that is non-US born and also has diabetes, again, red flag should be raised for TB.
More likely to need longer treatment and more aggressive disease.
Mm-hmm.
So.
And again, so the geography of these areas is kind of unique. Not many of us know where these are. So the Marshall Islands and Federated States of Micronesia are over in the Western Pacific. And a lot of these patients, it's interesting when you ask them where they're from, most of them will just say Micronesia, which is a region, kind of like Hawaii is in Polynesia, but because most people don't know where they're from, they're not used to people knowing the different countries or even the different atolls and islands that are there. So Republic of the Marshall Islands is right in there, but it's still quite far away from Federated States of Micronesia. And you'll notice each of those states that Yap, Chuuk, Pohnpei, Koshrai, they're not close to each other. So they're all very different. And I was lucky enough to be able to this summer actually go to Chuuk and see some of the healthcare there firsthand. And this is so important to us because Pacific Islanders are coming to the United States. So, and especially coming to Iowa, our population of Pacific Islanders has increased, as you can see on the slide, quite a bit. And this has to do with a lot of different reasons. One of the CDC officials that I was at described it very well. The Midwest NICE that we have is also very similar to being in these islands. So when I was in Chuuk, you know, the farmer wave, that's there. Saying hello, saying good morning, the courteousness, that Iowa NICE is really welcoming because that's common practice for these cultures. So I think we will continue to see more of these patients coming here.
And as you can see, a lot of them are leaving for many reasons, but the big reasons being jobs and then also climate change. So there's a lot of flooding that's happening in islands that's making areas harder to live in. Also the history of nuclear testing makes it harder to grow vegetables, grow food, things like that. So about a third of the country's population has left for other places, namely the Hawaii and the US mainland. So this is Dr. Rick Klein. He's one of two physicians in the US that are of Marshallese descent that has been trained as a US physician and works in Arkansas. And he has a wealth of information about things that are important to know about people from the Marshall Islands and how to care for them appropriately. And these things make a big difference, and I wasn't aware of them before. So I found it really helpful myself. A couple of things that jump out. America's loud. You know, we talk loud. Marshallese people do not. They're very shy. Marshallese is its own language. So they do learn English in school as a secondary language. And this can make it tricky because patients might understand enough to kind of get by in a visit, but they might not be understanding everything you're saying. So this is really important. I've had to use Marshallese interpreters, I know Sam has, for many patients to make sure that we understand what's going on and we communicate the plan effectively. But they might not say anything. They speak softly. As I mentioned, speaking loudly is considered threatening and rude. So, you know, you think about our practice, we're busy, we have to be loud, we have to be decisive. They have to do the opposite. So you kind of have to pull yourself in, kind of level things down, speak in a softer tone to try to help establish that trust. Family values, family is valued above all else, and also elders. Elders are highly revered in the community. People can be skeptical of Western medicine, as Sam had mentioned previously. That definitely has to do with history and with nuclear testing. Diet is affected, so pretty much everything is prepackaged because they can't safely grow foods in many areas. They're trying to do that now, but still they heavily rely on imports into their country to try to survive. They don't want to stand out. They're very quiet, humble. Sex is considered taboo in terms of discussions. So it's always good to preface discussions about sex as to why you're discussing it and that it's for medical reasons, and just to take it, to be sensitive to that. They also want to avoid conflict very often, often say yes to things. So, you know, you mentioned in this case, you mentioned having back pain, but didn't say anything else. A lot of times that'll happen when you get to know the patient more and more, and they feel more comfortable telling you things, you find out things later on. So just keep that in mind. And I think the thing that jumps out is working with these patients, they're all very polite and very kind. And when you get to know patients, you learn that that's normal and for their culture. So this has been really, I feel, the big thing that's been valuable to us to be able to help and work with patients more. Does anybody have questions or thoughts or things they wanted to add after hearing some of this stuff?
One person wanted to ask how many other cases in his circle that you guys saw, or you know, family, friends, those sort of things.
Yeah, Sam can talk about that.
Yeah, so it's interesting, you know, TB has such a stigma. This man, I believe there were only latent infections that resulted from his contact evaluation. And, you know, I am not privy to the entire thing, but as far as I'm aware, which he has a pregnant wife. We assume that they shared some airspace, and this man was probably very contagious for a long time, but she actually didn't end up with even latent TB. I think there were just a couple of kiddos in the house.
So fortunate, but yes, that is definitely a concern. And, you know, we've been working closely with our health department for the last, you know, over a year, you know, trying to communicate, just share information as best we can to help with that, because it can be tricky. A lot of people that are working a lot of them are coming for jobs, specifically with agriculture and manufacturing. So they also do live and go to other places for jobs, and sometimes will move. So Oklahoma is another state where there's a lot of people who work there. Arkansas is the biggest one because of Tyson. But patients will sometimes, you know, pick up and leave and go somewhere for several months and then go to a different place and then come back. So it's good to be aware of that because, you know, that will change kind of the information you have, who might be affected by what's going on as well. So we're just going to talk really briefly about TB. I'm just going to touch on a couple of things. I don't want to belabor it. I want to leave a little time for people to talk. So TB is, as we know and learn in school, aerobic non-spore forming organism that grows slowly and slower than most other bacteria. And that's one of the reasons it can be tricky to pick up. It can be hard to isolate, and that these cases can kind of linger without us finding them. And when you think of TB, you can also think of the tuberculosis complex. So there are other diseases that get lumped in as being similar biologically. So M. bovis is another one, M. africanum, as a large group of organisms together. Now, the TB transmission, of course, when we talk about it, who's contagious? Those with active disease. But we're going to talk a little bit more about the continuum of disease with TB, because we always learn it's kind of two different things, and there's a little bit more to it than that. How does it spread? It spreads through airborne shared airspace. And as we've been through COVID, we know how that works and how we need to be conscious of how to protect ourselves. Factors for transmission, of course, susceptibility to the host is a big one. Diabetes affects that a lot. HIV affects that a lot. Any kind of immune compromise, especially if people are on medications that might immune compromise them, say TNF inhibitors. So we're seeing more of that. Infectiousness of the patient, so how much organism they have, how much they can spread, environment, and the exposure or the nature in terms of how direct it was. Now, the big thing I wanted to emphasize in this slide is it talks about the continuum of disease in terms of infection to having full-on disease for TB. And if you look at the right-hand side, those three kind of outlines of the mannequins there, you can see that there's a depiction of latent infection in the middle. And then you see a subclinical designation in between, and then you see active TB disease on the right. It's very well recognized now that there's a lot of people who are in this kind of subclinical in between category, and you'd actually kind of consider them TB disease or active. This is a state when it's not quite ramped up to the level of full infection, but it's in the process of doing it. And you can see that sometimes on x-rays where you see an area of a granuloma or an area that maybe was calcified or not active before, starts to develop some inflammation around it, can start to have some infiltrate around it, and nothing else. And so I think there's some TB disease that gets missed that's in this category, and it can present in a lot of different places. So it's just good to be aware of that continuum. So just to clarify some of the terms we were throwing out. So when we're talking about TB infection, we're talking about latent TB. So we're talking about somebody has the organism, they're not having symptoms right now, but it's there. TB disease being active TB, like the case that we just talked about. IGRA, the interferon gamma release assay, this is the test that we use here for TB testing, and that's the blood test for immune response to the presence of organism. So of course, it's not a direct test for TB, but it tells us if there is an immune response. And there are things that can trigger false positives and negatives for this. And then of course, the traditional TB skin test, the PBD that we know as well.
We're good. Yeah. So when you start with testing, I mean, you obviously have to screen the patient. You're not going to test every single person that comes into the clinic for TB, but it is actually recommended under the USPSTF that we check in on our patients, see if we think that they need testing for TB. So the questions, there's a little picture there from the CDC, but the questions that we're going to be asking are, you know, where were you born? Have you stayed anywhere outside of the US for longer than 4 weeks? Do you have any planned or current immunosuppression? And then have you had close contact with someone who's had TB? And especially if you're talking to people who are non-US born, it may be better to ask this in different ways. Does anybody in your house have a nurse come and give them medicine every single day? And then you could look into that a little bit further. And then additionally, I ask patients, have you ever tested positive for TB or had a positive PPD? The number of CNAs, healthcare workers, things like that, to say, oh yeah, my TB test is always positive, but my chest x-ray is negative. And then they've never really been counseled that that means that they have latent TB and that they could take medications for that. And then additionally, do you have any cough, fever, weight loss, night sweats? Any patient who you assess has risk for TB and has some of those classic symptoms really should get a chest x-ray right away. Learn from that first case. That patient, when I saw him, very clearly looked ill. Even though he wasn't complaining of anything, I knew that he was frail. And if that patient, if same scenario were to happen again, knowing what we know now, he would have left with a chest x-ray before, you know, waiting for all the testing and things like that. And then if the screening is positive, then yeah, we need to do some testing, which could be a PPD, a quantiferin gold, or a T-spot. And the differences between these two, the PPDs and the IGRAs are set up in this table here. The nitty gritty of them is that they both work by stimulating an immune response. And so this can be kind of a difficult concept because most of the tests that we do are, you know, your blood sugar is 89, your blood sugar is 89. But we might get false positives and negatives like Dr. Burr said. So we might get a false negative for both the PPDs and the IGRAs if there is active infection, and that includes active TB, or in this 8 to 10 week window after initial infection. So we said TB replicates very slowly, and TB is very evasive, and it can take 2 to 8 weeks for the immune system to really recognize it, the macrophages to start forming that granuloma. So in that period of time, that person's quantiferin gold is going to be negative. And the PPDs, the downside to those two is, of course, it has to be stored correctly, it has to be administered correctly, and read correctly. You may get a false positive with the PPD for other non-tuberculous mycobacterial infections, misinterpretation, or also the BCG vaccine. And I want to make a point that BCG vaccines, you know, we don't give them in the US, but in other countries, they're given to young children generally to prevent TB meningitis. If you have a 60-something-year-old who says, oh, my test is positive because I got BCG when I was a kid, that's not likely. That effect wanes over time. And so if you've got someone over the age of really probably 18, you can pretty surely consider that a positive. Arguably, really over the age of 5, they shouldn't have a positive PPD because of the BCG vaccine. Right. And then our IGRAs really are only cross reactive with a couple of other mycobacterial infections. So that is a benefit to that. The pros to the PPD is that they're very cost effective. And for the IGRAs, you know, like I just said, they're not very cross reactive with other non-tuberculous mycobacterium. But the PPDs have a lot of cons. So you have to return for reading. I don't know if anybody out there practices in a place where their patients return when they say, but it's not here. And the results are very much on the condition of good administration and reading, and patients are a lot less likely, in my experience, to believe this. You know, it sounds kind of wild. We're going to inject your arm with this solution, and it has to be done perfectly, and you need to come in between 48 and 72 hours, no less than 48, no more than 72. And depending on how big it is and your risk factors, I'm going to decide if you need antibiotics for however many months we decide. That just sounds kind of wild. And then with the IGRAs, the downside on there is that they're not well studied in those under the age of 2, but most experts would probably say that you can use them. We just don't have a lot of data. And then just some FYIs, serial PPDs will not lead to a false positive. And for the IGRAs, once it's positive, it's going to stay positive. So if someone has been tested for TB in the past and it's positive, you know, there's really not a reason to repeat it because, again, it's a measure of immune response. Ideally, they're going to continue that immune response.
So I'm gonna just touch on a couple of these slides before we finish so we can keep things quick and have some time to talk. But in terms of infection follow-up, if somebody triggers a positive test for screening, you wanna get a chest x-ray, you wanna review their symptoms, make sure they don't have any pulmonary or extrapulmonary symptoms. HIV testing is recommended for anyone who tests positive for latent TB. So that is important because it changes kind of your risk of having extrapulmonary TB or more severe presentation of disease. And then, as I mentioned, just going through these symptoms to make sure none of those trigger positive and working those up, we find them. This is just a regimen of latent TB treatment. Just wanted to touch on the options. In the state of Iowa, primarily rifampin gets used for 4 months as the first line. I think it has to do with availability and effectiveness. This can change depending upon what's available and cost effective. Usually once weekly isoniazid and rifapentin are used for specific individuals for latent TB treatment. Isoniazid alone is kind of a backup if rifampin or if INH rifapentin is not an option. Now, in identifying disease, as we talked about, our case was a pretty typical case in terms of how it looked on X-ray. And it was predominantly upper lobe bilaterally. It did have cavitations, but one thing to keep in mind is not all of them present that way. TB can be anywhere in the lung. So sometimes it can be in the lower lung. It might not have cavitations. You might have adenopathy, especially in younger patients or children. May have effusions that can be more complex and harder to diagnose. So just good to keep that in mind, and also to keep in mind that if you're not sure about the presentation, there's always a CT scan to try to help define that a little bit better if you're not getting a clear diagnosis. And in terms of active TB diagnosis, remember that PPDs and IGRA tests are screening tests. So up to 20% of people can have a negative test, as we talked about. So think about their epidemiology, think about their symptoms. Do you still need to do further testing to figure out what's going on? Sputums, of course, should be 3 daily successive ones, at least 1 in the morning. And I just wanted to touch on that if you have positive screening and chest X-ray findings, remember TB can be anywhere in the lung, not just the upper lobes. Symptoms and findings concerning for active TB disease should get 3 sputums, even if there's an inconclusive X-ray, if you have a high index of suspicion. If they have extrapulmonary TB, you definitely want to evaluate for that with sputums. And then also remember demographic information and risk, as we talked about. Just touch on this. I just wanted to also mention that TB can be anywhere, again, literally anywhere in the body. So this is just an overview of the many places it can be and the many things it can cause. In our patient, I think they had probably 6 different locations that were affected, but there were probably more that were affected and we weren't aware of it. And the big ones are knowing which ones are going to affect treatment, which we'll talk about in a little bit. And I just also wanted to mention that if you're trying to diagnose extrapulmonary TB, this can be hard. So you probably need a specialist to help you out with it, but just being aware that thorough testing is important. And a lot of times the gold standard is tissue. So if you can't find anything in fluid, such as the CNS or in peritoneal fluid or in pleural lung fluid, you often have to try to get tissue biopsy if you're not sure. But remember, these get into some complex discussions and situations in terms of deciding, is it better to treat, is it better not to treat? And this is where we have worked with specialists that we'll mention at the end here that have helped us with these decisions and management. So these are the medicines for treatment, as we know. The 4-drug regimen to start for 2 months, isoniazid, rifampin, pyrazinamide, ethambutol, and then after 2 months of confirming clearance or at least improvement without any positive TB on culture, you can go to the continuation phase, which is just isoniazid and rifampin for another 4 months, for 6 months. Now, as I said, there's always caveats to everything. And the big thing I wanted to emphasize was there are situations where 6 months of treatment is not enough. And so it's always good to keep that in mind. So patients that have really significant disease to start with and remain culture positive after 2 months, people who have risk factors like diabetes with significant disease or immune compromise of any way, people who have HIV, and then also extrapulmonary forms. So if people have TB meningitis, they very often need 12 months of treatment. If people have joint or spinal involvement, like our patient, they need at least 9 months of treatment. So it's just good to be aware of the exceptions, because that is what necessitates further workup to make sure that you're treating the patient appropriately.
And that would go with saying too, that if you find a patient with pulmonary disease, that, you know, putting them on the 4-drug regimen doesn't mean you just stop. And if they have signs of something else, it's not, well, they have TB, so it doesn't matter. So I'm just going to put them on the meds. It doesn't matter where else it is. It does matter.
And I just wanted to touch on multi-drug resistant TB. We don't fortunately see this often in Iowa, but it's out there and we need to be aware of it. So if people are from countries where there is multi-drug resistant TB, if you know they've had treatment and they've failed before, Or if they've been in direct contact with someone with a known MDR case, that you basically need to get the health department involved immediately, no matter what's going on, and try to help you out with sorting things out. So we bring this up because, as I said, this was like the first case that walked into us that was really obviously TB, and we've had many more since. And we just wanted to share our experience and what we found to be helpful. So it's very possible that something could walk into your clinic, in your ER, and in whatever setting that looks like this, and you have to start initially evaluating and trying to diagnose it. So the first important step is not to panic. That's really important. And then the next one is, if you're suspicious at all and you think that you need to evaluate, just go ahead and do it. Get a chest x-ray, contact your health department for sputums, and that gets that process going. If you're not sure, just call them. I know in some settings, the local health department might not have all the resources to help, but they can contact the state health department to help you. Remember that screening tests are just that, screening tests, so they don't always tell you exactly what's going on, and you can take that into consideration. 20% of active pulmonary TB is sputum culture negative. So there are situations where people just start on treatment because everything else fits TB, but we're just not getting the bug. Remember, it grows slowly. So that's a situation where people will help you to make that determination, especially with the state health department, the other resources we'll mention, to decide when do we need to do that. And then also remember extrapulmonary TB. You don't want to miss that. And this lists the stuff that can help us.
So Alan Lynch is the TB program manager for the state, and Shirley Hested is the TB nurse consultant. They're super helpful. TB is an often forgotten infection, so anybody who has any vested interest in taking care of TB is going to be kind to you. So there's no issue in calling and asking for help. So if you're not getting assistance with your county, or maybe they say this a little over our head, then, referring to the state is a great option. And because TB is a not common infection in the United States, even some infectious disease specialists, if you're not in an area where it's prevalent, they don't see it very often. So we have these centers for excellence that the CDC designates, and they're across different regions of the country. They kind of take ownership of different states, and they assist with consultation and expert recommendations. So ours is Mayo Clinic. So if you Google Mayo Clinic TB Center for Excellence, you'll find some information there. And if you are stumped or just need assistance, or maybe just want someone to look over something and say, you think this is a good plan, you can send a consultation to these Mayo Clinic experts and go over everything, and they will give you a recommendation. The other centers for excellence, we listed those on there, but really the main reason I did that is because they all have a lot of interesting resources available, and they're generally free. And you can go on their websites and download them. And then I should mention, all of these consultations are free to you, free to the patient. Again, it's supported by the CDC. There's a book called the CDC Core Curriculum on Tuberculosis. You can download that as a PDF. And then the Heartland National Tuberculosis Center, they actually used to be our Center for Excellence in Texas. Dr. Burr and I got to know the co-medical directors very, very well. And they have a YouTube channel, and a lot of their webinars they post for free on there. So it's a nice way to get on-demand information regarding that stuff. And the picture here, so I mentioned that I went to CHUK this summer. There was a mass screening initiative in CHUK, which is one of the states in the Federated States of Micronesia. And we were collaboratively testing for TB, leprosy, and diabetes, and helping people get diagnosed and treated for these infections. So that's that picture that's over there.
So, what questions do people have or want to talk about?
Guys, I first wanted to say thank you. That was amazing. I loved the presentation. I did have a question. So I get to take care of patients at a free clinic, and a lot are not citizens and undocumented, and often nervous to be kind of tracked by public health. So I guess, how do you handle that? And can we reassure them that we're not providing their patient, their information to governmental agencies? I don't know. I was just curious how you handle that.
That is hard. I think one of the ways we handle it is emphasizing that, here it's for their care. It's for them to help them get better. There is still stigma about it and fear. I know at least in the Marshallese community, there's a lot of fear about that and DHS connections being inappropriate. I think a lot of it is if you can be an advocate for the patient, and if there's any situation where you think something isn't necessarily for their care, you can step in and help them. That makes a huge difference. Also, these cultural suggestions, I think they just help in guiding us and helping build trust. And I think that does a lot too. Sam's thoughts about that.
Yeah, I mean, I just this past week am encountering a patient who probably has TB and is undocumented and new to the country. And we kind of just reassured the patient that that's not their intention. They want to make sure you get treatment and get better, because if we were to report you and you didn't take your medicine, you could get other people sick. So they're not going to do that. It's in our best interest to make sure that you stay put where you're at, and we give you your medicine until you're done.
Thank you.
Any other questions of the chat here, maybe?
I was gonna say in the chat, somebody pointed out something really fun that they said back in the old days, when they would have upper lobe TB involvement, they would turn the X-ray upside down so that your eyes would be more drawn, to the upper lobes, but then they're the lower lobes. And I checked on Epic, and you can do that. You can flip the X-rays around. So we can still do it.
It's nice.
Yeah.
Oh, I didn't know that.
And I think Dr. Burr pointed out the subclinical TB as being really important. And I think if you screen more, you will find them. And that's what we have found. People coming in and we say, hey, you're at risk, let's screen you. And they have no symptoms that they complain of. And then, oh, what do you know? The quantiferin goes positive. And we say, oh, it's probably fine. Come in for a chest x-ray. And then, oh, what do you know? There's a right upper lobe opacity. And so the more you look, you'll find it.
And I'm really sorry, I got a page during your talk, but how did this patient end up doing? Did he do okay on treatment? And
yeah, so one of the most common questions I get asked when we talk to experts about this case is, did he survive? And he did. He unfortunately, again, when we talk about TB, there's a real push from the WHO to talk about comprehensive and family-centered care. But this patient had to miss the birth of his son because he was isolating and didn't get to meet him until he was about 6 to 8 weeks old. And had he been diagnosed previously, that wouldn't have been the case, because he had a negative chest x-ray, then presumably didn't have pulmonary TB at that time. So he was on treatment for a total of 13 months, and as well as it could go, had some retained fluid loculations in the abdomen that we think will hopefully eventually go away on their own. But the chest x-ray comparisons are honestly kind of wild to see how much improvement's there. Probably will have some chronic post-tuberculosis lung disease, but otherwise, no neurological damage.
And he was also on steroids because he had tuberculosis and evidence of CNS involvement. So he was on a taper for about 4.5 months.
Yeah.
Yeah.
Mm-hmm.
And that can be a challenge too, is sometimes that gets tapered too quickly if people have pretty extensive disease. So he was on it for quite some time, and we worked very closely with at that time, the Heartland Center in Texas, and their consultant, Dr. Seaworth, who's a wonderful resource to help treat that patient. And actually he did very well.
Mm-hmm.
that's amazing. Well,
Yeah.
I think since it's 1 o'clock, we'll end it here. Obviously, if people have other questions, feel free to stay on, but thank you guys so much for presenting. It was fantastic to hear and learn about.
Thank you. We appreciate it.
Yeah, thank you.